Good morning, good afternoon, and good evening. Thank you for joining us today for our webinar, Cardiovascular Autonomic Testing Revisited. This is Haley Carleton from Inside Scientific, and I am very pleased to be your host for today's event. During today's webinar, sponsored by Finite Medical Systems, Dr. Artur Fedorowski will explain the physiology of syncope and orthostatic intolerance. He will discuss the background behind the current guidelines and advise on the practical skills required to perform a successful cardiovascular and autonomic workup from his extensive experience. We are now going to be joined by Eric Altena, Managing Director of Finite Medical Systems, who would like to say a few words.
Thank you, Haley. Thank you and Inside Scientific for hosting this webinar. And thanks to all the attendees for joining the webinar. It is an honor for Finapres that we can contribute to this webinar via sponsorship. At Finapres, we want to contribute to a better healthcare by developing and providing continuous, non-invasive blood pressure measurement systems. With our 30 years of experience, we take pride in assisting healthcare professionals and researchers with their daily operations. Research and diagnostics of autonomic functioning is an important area for Finapres. We encourage all the work that is being done in the autonomic testing labs by many specialists all over the world, and we like to support sharing further knowledge about this. Speaker of today, Dr. Fedorowski, is a well-known and very experienced key opinion leader, and I would like to give the word to him now to start the webinar about cardiovascular autonomic testing revisited. Dr. Fedorowski, the floor is yours whenever you're ready. Thank you.
Thank you, Eric, for your very kind introduction. And this is my great honor and a real pleasure to be with all of you and to discuss cardiovascular autonomic testing, which is a very important part of assessment of such conditions like syncope and cardiovascular dysautonomia. Before we start, I would like to ask you a few questions which may seem very trivial to some of you, but which may give us a sort of understanding how you, a part of audience, how you understand the field that we're going to discuss in a few minutes. The first question is, what are the most common causes of transient loss of consciousness? Answer 1, hypoglycemia, orthostatic hypotension, epileptic seizures. Answer 2, epileptic seizures, head trauma, or cardiac arrhythmia. Answer number 3, vasovagal reflex, cardiac arrhythmia, orthostatic hypotension. Answer number 4, psychogenic pseudosyncope, hypoglycemia, or vasovagal reflex. Please select the right answer. This question is important as in my own experience, many of clinicians and even common people believe that when you lose your consciousness, it must be due to conditions that actually are not directly related to transient loss of consciousness, such as stroke or metabolic problems, and mentioned in one of the answers here. So I hope that everyone have the opportunity to select the answer. The right answer is number 3. The most common causes of transient loss of consciousness are vasovagal reflex, cardiac arrhythmia, and orthostatic hypotension. All of these 3 causes are part of syncope etiology. We're going to discuss it a little bit later. Now let's move to the question number 2. What can be diagnosed using head-up tilt testing? Answer number 1, cardiac arrhythmia, orthostatic hypotension, epileptic seizures. Answer number 2, epileptic seizures, vasovagal syncope, cardiac arrhythmia. Answer number 3, POTS, arterial hypertension, inappropriate sinus tachycardia. And answer number 4, orthostatic hypotension, POTS, vasovagal syncope. Please vote now. Again, this question refers to one of the most basic diagnostic methods for cardiovascular dysautonomia. This method may even detect other problems, other pathologies, but is especially designed to detect pathologies or pathologic responses for circulatory system. And I hope you are well aware which cardiovascular disorders can be detected by head-up tilt testing. So I will give you a few more seconds. Yes, for you who selected answer number 4, this is the correct answer. Orthostatic hypotension, POTS, and vasovagal syncope are 3 conditions that may be easily detected using head-up tilt testing. Thank you for taking part in this poll. Now, you may ask yourself whether loss of consciousness is this a problem? Is there really a problem? 1 to 2% of all emergency department visits are actually due to syncope. So we are talking about huge numbers of people attending emergency departments all over the world. However, you may be even more impressed by the number 30 to 40% of all people who will faint at least once in their lifetime. So syncope as a clinical problem affects a lot of people and creates a lot of anxiety among patients who in some situation cannot obtain the right diagnosis. So that's why we selected this subject for today's presentation. We shall talk about the pathophysiology of syncope and cardiovascular dysautonomia, the background behind the current guidelines on syncope management, and the practical skills required to perform a successful cardiovascular autonomic workup, illustrated by real-world examples. We start with cardiovascular dysautonomia and syncope and the pathophysiology. So, what is cardiovascular dysautonomia? Actually, if you look at this diagram, you will see 2 major components of the circulatory system: the pump, the heart, and the pipelines, the vessels. Cardiovascular dysautonomia may affect both the heart and the vessels. And you may see the list of different conditions that are dependent on the disorders in the control of circulatory system. One of these conditions, arterial hypertension, is affecting millions of people worldwide. However, in the field of syncope, we will focus upon orthostatic hypotension, vasodepressive vasovagal syncope and carotid sinus syndrome, and cardioinhibitory vasovagal syncope and cardioinhibitory carotid sinus syndrome on your right-hand side. The blue color means that the system is inhibited, whereas the red color means that the system is hyperactivated. When we talk about syncope, it is very important to understand what syncope is. And according to current guidelines, the definition of syncope is transient loss of consciousness. Duration maybe 30, 40, up to 60 seconds, sometimes more than 1 minute, due to transient global cerebral hypoperfusion, meaning when the blood pressure must go down. The brain cannot get the sufficient supply of oxygen for a short period of time, characterized by rapid onset, short duration, and spontaneous complete recovery. Now let's move to the next slide, next diagram, which demonstrates a major mechanism of syncope. The first one is vasovagal syncope. This is the reflex syncope, mediated through vasomotor center in medulla oblongata. Different triggers like orthostatic challenge, like emotional triggers, pain may evoke response leading to abrupt bradycardia and vasodilation leading to temporary loss of consciousness. The next mechanism in the list, very similar to reflex syncope, is baroreceptor dysfunction, carotid sinus syndrome, leading to the same sequence of events induced by improper signals from carotid sinus baroreceptors, otherwise preserving the right perfusion in the brain. Next, a huge group of cardiac disorders. In the first cardiac arrhythmias in the first place, then the structural changes that may compromise the cardiac output may also lead to temporary loss of consciousness. And finally, the autonomic failure leading to improper response from peripheral vessels, leading to gradual or sudden onset blood pressure fall, and in consequence to temporary loss of consciousness as well. These are the four main mechanisms of syncope. If we put them in a diagram in this nice classification borrowed from current European syncope guidelines, you may see that syncope is the most common cause of transient loss of consciousness. Then patient may lose consciousness due to epileptic seizures as well. But please take a look at this diagram. On your left-hand side, you see the main etiologies of syncope, and you can see that 35 to 40% of population will experience syncope during their life, whereas epileptic seizures may affect between 0.6 0.9% of the whole population. So epilepsy is 50 to 100 times less common than syncope due to circulatory collapse. You will note psychogenic pseudosyncope more frequent in younger patients, and head trauma, which is not as frequent as syncope. To understand the syncope presentation in different ages, it is important to understand a sort of age gradient in syncope etiologies. Orthostatic hypotension and cardiac causes are very uncommon among younger people under 40 years of age, whereas the same causes become more and more prevalent with advancing age. And in the age group over 75 years, almost half of all the patients will experience either orthostatic hypotension or cardiac problems as a cause of syncope, whereas reflex syncope is rather stable, affecting between 50 and 60% of all syncope patients. Interestingly, these two major etiologies, reflex syncope and orthostatic hypotension, may be very efficiently detected using cardiovascular autonomic testing. This is emphasized by current European syncope guidelines. That's why we are now moving into the area of cardiovascular autonomic testing as a part of integrated syncope evaluation. This is a very important diagram from current guidelines, and here you can see two paths of investigation in uncertain diagnosis of syncope or in so-called unexplained syncope. These two pathways we can call them cardiac pathway and autonomic pathway. Cardiac pathway may detect 10 to 15% of all etiologies, whereas autonomic pathway can cover between 70-75% of all syncope causes. In this diagram, in the central part, you will see on your left-hand side echocardiography, ECG monitoring, external or implantable devices, electrophysiological studies, stress tests, and coronary angiography. Of these, ECG monitoring is the most important part of the investigation. Whereas on your right-hand side, you will see cardiovascular autonomic test as the major part of autonomic evaluation, plus ECG monitoring in inconclusive assessment. So please keep in mind this diagram, because this is a part of background on which we have built the concept of cardiovascular autonomic testing in syncope. Now, to perform the cardiovascular autonomic testing, you need staff, experienced staff, you need training, and you need equipment. We used to promote concentrating all these assets into syncope units, virtual or physical. The essential equipment of syncope unit consists of usual ECG monitors, or ECG devices, and non-invasive beat-to-beat blood pressure monitor, plus tilt table, which both compose the major part of cardiovascular autonomic assessment. Then you may need Holter monitors, external and implantable loop recorders, 24-hour blood pressure monitoring, and knowledge about basic autonomic functioning tests, which can be performed in the cardiovascular autonomic lab, which we are going to discuss in a while. So, to compose a syncope unit, you need access to cardiovascular autonomic lab, which is well equipped, and implantable loop recorder services. This is a picture from our lab in Malmö. Our unit has been in operation for over 10 years and covers the southern part of Sweden. This lab needs priority access to additional tests such as echocardiography, 24-hour ambulatory blood pressure monitoring, Holter ECG, exercise ECG, and other less common tests. And the workup should be based on current European Society of Cardiology recommendations. Now, talking about basic cardiovascular autonomic function test, we should understand which components are the crucial ones to perform the effective testing. Active standing, Valsalva maneuver, carotid sinus massage, tilt testing are most important, and ambulatory blood pressure monitoring and ECG monitoring are important as well. Then the major part of cardiovascular autonomic function test could be performed in cardiovascular autonomic test laboratory, and we will talk about it more using different real-life cases in a while. So now let's walk into the cardiovascular autonomic testing lab. I will show you a few practical examples of different tests performed in our lab. These are real-world examples, real patients that were evaluated in our laboratory. You may remember the active standing test as a part of cardiovascular autonomic workup. This is a woman, 20-year-old, with Ehlers-Danlos syndrome and post-orthostatic tachycardia syndrome with unexplained syncope. And you see the result of active standing test, the abrupt blood pressure fall on standing, leading to dizziness, pre-syncope, and it gets resolved while the patient is sitting again. You see even the impressive heart rate increase typical for postural orthostatic tachycardia syndrome. Now let's move to The next example, Valsalva Test. This relatively young man, 37-year-old with unexplained syncope, was actually diagnosed with orthostatic hypotension. During the autonomic workup, we performed this Valsalva test. You may see this steep blood pressure fall in the first part of Valsalva test when you are trying to breathe out with your mouth closed, with a mouthpiece. You measure the counter pressure of 40 millimeter mercury, and during 15 seconds there is an increased pressure in your airways, which leads to response to cardiovascular autonomic response. In this case, this response is pathologic, blood pressure goes down, and then when the mouth are open, you see that the blood pressure, instead of going up, according to the dotted line, the blood pressure doesn't rise as much, and this is a pathologic impaired response, meaning that the autonomic nervous system in this patient is damaged. So it might be a sign of neurogenic orthostatic hypotension, which was diagnosed in this case. Next, let's move to deep breathing test. These two apparently indifferentiable two young women with postural orthostatic tachycardia syndrome show different pattern of deep breathing test results. On your left-hand side, you see the normal fluctuation of both blood pressure and heart rate. On your right-hand side, you see absence of this fluctuation. The response on your right-hand side is pathologic and means that the autonomic control of circulation is severely impaired. This patient is more affected than the patient on your left-hand side. And the cardiovascular drugs, adrenergic, anti-adrenergic drugs might be very useful in this case. Now, I would like to tell you a little bit more about carotid sinus reflex, carotid sinus syndrome, which seems to be less known. How does it work? Actually, you have two baroreceptor centers on both sides of your neck in the carotid artery sinuses. And when you press the carotid sinus on one side, it may provoke the carotid sinus reflex, which is pathologic. It means that the other side does not compensate for the externally imposed increased blood pressure using your fingers in this case. So you can see that this is almost the same reflex as in vasovagal type of response. The pressure on carotid sinus evokes bradycardia and vasodilation and hypotension and syncope. Now, you would like to see a real-life patient, I guess. And this young woman, 50-year-old, with unexplained syncope, actually in her bed while sleeping when she was turning her head, was investigated in our lab, and you can see that carotid sinus massage on her right side evokes blood pressure fall, syncope, and asystole, cardiac arrest, actually, of almost 8 seconds, and this patient, 10 seconds actually, and this patient was effectively treated with pacemaker. So this is a typical patient who would respond to pacemaker therapy. We mentioned reflex syncope in a mechanism of carotid sinus dysfunction. Now we are moving to classical vasovagal syncope, which you may remember is responsive for about 50% of all syncopal episodes in all ages. This is a typical example of head-up tilt test, orthostatic challenge, nothing's happening. Then we potentiate the effect of the test by using nitroglycerin, evoking a little bit of tachycardia, a little bit of hypotension. And this woman is very susceptible to this provocation, develops vasovagal reflux with reproduction of the historical symptoms, which patients can memorize, and you can see both blood pressure fall, deep hypertension, and bradycardia accompanying the hypotension, meaning that this is a typical vasovagal reflex with reproduction of spontaneous attacks. The diagnosis is established here. In some cases, vasovagal syncope may lead to cardio inhibition. You might certainly remember one of the first diagrams with cardio-inhibitory vasovagal reflex. This is a type of cardio-inhibitory vasovagal syncope, and in this middle-aged man, 53-year-old, with recurrent unexplained syncope, in this case, we were able to establish the diagnosis using head-up-tilt testing, nitroglycerin provocation, and in this case, you may see that although the patient demonstrates blood pressure fall and dyspnea, he faints first after the cardio inhibition starts and produces sinus arrest. You may try to guess how long the sinus arrest was in this case. Actually, it was 63 seconds, one of the longest sinus arrests we have ever experienced in our lab. And this patient was effectively treated with pacemaker. Moving from vasovagal syncope till orthostatic hypotension, you should remember that orthostatic hypotension is a chronic condition, whereas vasovagal syncope is more paroxysmal condition with some underlying susceptibility. This a little bit older man, 82-year-old, presented with classical orthostatic hypotension. You see the profound blood pressure fall at the very beginning of head-up-tilt test, and in the end, he cannot stand anymore and he's tilted down because of syncopal episode. What I want you to see here is this line, which illustrates cerebral saturation, cerebral oxygenation. You may see that the cerebral oxygenation is slowly, gradually going down. And at one point when he is about to lose his consciousness, it reaches the level under 60%, which is the critical level for cerebral saturation, which predisposes to fainting. Although classical orthostatic hypotension is well known, there is another condition, delayed orthostatic hypotension, which is actually even more common with advancing age. This man, 65-year-old with unexplained syncope, was diagnosed with this condition. You may see that the blood pressure is slowly, gradually going down over the period of more than 10 minutes until test, and that he is not fainting at this moment, but he's about to faint when we perform carotid sinus massage. So this is a combined autonomic disorder, afferent by carotid sinus syndrome and afferent by orthostatic hypotension. So we tested his resistance to orthostatic challenge by adding nitroglycerin, and you can see here that nitroglycerin induced profound hypotension without real signs of vasovagal reflex. So this is more orthostatic hypotension and carotid sinus syndrome without signs of vasovagal syncope. A very complicated case, actually. And now we move to the younger segment of patients. This young woman, 50-year-old, with profound orthostatic intolerance, presented with postural orthostatic tachycardia syndrome. Here you can see a very abrupt heart rate increase of more than 40 beats per minute, associated with dizziness, intolerance, discomfort, and at one point, when cerebral saturation goes down and gets closer to 60% limit, this young lady cannot stand anymore, and the test is terminated due to presyncope. This is a very symptomatic postural orthostatic tachycardia syndrome case. Moving for a while out of the lab, out of the cardiovascular autonomic lab, we are now entering other monitoring devices. The regular 24-hour Holter ECG may actually demonstrate some forms of cardiovascular dysautonomia, which may provoke syncope. In this case, you see postural orthostatic tachycardia syndrome with very steep increase of heart rate in different times during the 24-hour period. And on the lower panel, you see inappropriate sinus tachycardia with much higher average mean heart rate during the whole day. In the upper panel, you see that patients with postural orthostatic tachycardia syndrome demonstrate the characteristic dip during heart rate dip during nighttime, which is typical for POTS, not typical for inappropriate sinus tachycardia. You can differentiate the two conditions using this quite simple method of Holter monitoring. You can use 24-hour ambulatory blood pressure monitoring for detecting cardiovascular dysautonomia. This 65-year-old woman with syncope, with unexplained syncope, was diagnosed with orthostatic hypotension. We could demonstrate profound hypotension during the day, in the morning hours, after lunch, and in opposite, you can see the supine hypertension, meaning that, during the night, the blood pressure increases enormously over the level of 160 millimeter mercury during nighttime. So this is the typical reverse dipper, and these patients should be treated during daytime against hypotension and during nighttime against hypertension. Okay, now cardiovascular autonomic testing is a part of syncope management as well. This is not only for diagnosis. And in this very nice study by Bob Sheldon and his group, they performed a sort of meta-analysis of different intervention studies in syncope, showing that patients who underwent cardiovascular autonomic testing, they received a diagnosis of vasovagal syncope during the testing. Actually, even if they were not treated with drugs, with cardiovascular drugs, they were treated with placebo only. In this group, the frequency of syncopal events has diminished by 50%, which is quite impressive. We have arrived at one of the most important slides here. This diagram shows the decision pathway for a reflex syncope and pacing. Actually, this is a very nice diagram and pathway that we used to follow in any kind of patients, not only for pacing. In unexplained syncope, when the syncope is severe, recurrent, unpredictable, especially in a little bit older age, we start performing cardiovascular autonomic testing. Cardiovascular autonomic testing is based on carotid sinus massage and tilt testing with different elements, which may be aided by active standing, of course, and Valsalva and so on. Once we find cardioinhibitory response, these patients should be paced. However, if the answer is not available, if the test is inconclusive, if you have doubt, when in doubt, no doubt, one might say, then you should proceed with implantable loop recorder, which may give you an answer in cases where the events are not so frequent. By implanting a loop recorder, you may detect cardiac arrhythmia, which is potentially treatable, normal recording or artifacts may be suggestive of psychogenic pseudosyncope or epileptic seizures. To show you how it works, these are 4 typical patterns of usual findings from implantable loop recorders, which by themselves are diagnostic in 10 to 25% of cases. Now, this is very important here. These 4 diagrams present actually 4 patients which were indifferentiable by the history, by the initial workup. But when implanted with implantable loop recorders, the first one demonstrated sinus arrest, probably in the mechanism of vasovagal syncope. The other one demonstrated paroxysmal AV block, which could be treated with pacemaker. The third one demonstrated actually supraventricular tachycardia, tachyarrhythmia instead, and was treated with ablation, with electrophysiological study. And the fourth one, in the fourth one, we detected epileptic seizure. You may see the tonic and then clonic activity typical for epileptic seizures. So for these specific patients, the implantable loop recorder was diagnostic. Before we stop, I would like to promote this GPS algorithm. Otherwise, you use GPS to get home safely, and you can arrive at the diagnosis safely using the same algorithm for syncope. G is guess in this context. You have to guess what happened by asking your patients, asking about syncope scenario, orthostatic symptoms, prodromes, triggers, other aspects like spasm. You can look at the ECG and the telemetry findings. You can perform supine blood pressure plus active standing, and you can use some imaging techniques like echocardiography or angiography. If it doesn't work, in 50-60% of cases it doesn't work actually, you may try to provoke the symptoms by using cardiovascular autonomic testing. And reflex syncope and autonomic failure, orthostatic hypotension, which represents 60-70% of all causes, may be detected using these specific tests that we discussed just a few minutes ago. And then if it doesn't work, you may use the C method, meaning S, what happens, see what happens, ECG monitoring, long-term monitoring with implantable devices, or in some cases, video EEG monitoring at the neurology department, especially equipped with these devices, or bystander video recording. You can use your mobile phone to record what's happening to the patient when the attack occurs. And this is very useful method recommended by current European syncope guidelines. So, some take-home messages for you. Cardiovascular autonomic testing is crucial for diagnosis of unexplained syncope, as it may potentially identify up to 70% of syncope etiologies. This testing is important for the diagnosis of cardiovascular dysautonomia as the underlying cause of unexplained symptoms of syncope, orthostatic hypotension, such conditions like postural orthostatic tachycardia syndrome, inappropriate sinus tachycardia, chronotropic incompetence, especially in older patients, and other dysautonomic conditions. And finally, cardiovascular autonomic testing should be performed by trained staff with access to autonomic laboratory, meaning well equipped with tilt table and with bit-to-bit hemodynamic monitor, and prolonged cardiovascular monitoring methods such as implantable loop recorders. Thank you very much for your attention.
Thank you so much, Artur. Thank you for your presentation. And if you have any questions for either Artur or Eric, please submit them through the Q&A widget now. Fantastic. And we've received a number of great questions already, so let's just jump right into our session. So, Artur, our first question is for you. Can we say that the variability of systolic blood pressure characterizes the autonomic regulation of contractile function of the heart?
Yes, to some extent. we have to remember that systolic blood pressure is maintained by heart contractile power and by cardiac feeling. So the heart is controlled by the autonomic nervous system. And, its contractility is controlled by sympathetic branch of the autonomic nervous system, by adrenergic part. But there is another important component in heart contractility. So this is cardiac feeling. So the heart cannot pump blood that is not there. So there must be properly functioning venous return to fill the heart ventricles so that heart can pump the blood out of its ventricles. So we can say that variability of systolic blood pressure characterizes the autonomic regulation of contractile function of the heart and the control of the vascular tone as well.
That's great, thank you. Arthur, bearing in mind COVID-19 for infection control, how can patients safely perform the Valsalva maneuver?
Oh, this is a very good question. Actually, especially currently, very important. So in our lab, we do not recommend patients come if they feel any signs of infection. Of course, they are not allowed to come for investigation to our lab. Then for Valsalva maneuver, we use single-use mouthpiece. So our measures are those who are usually applied in the whole healthcare system. There is nothing special than just the common sense measures. I don't know what Eric would say about it. Would you like to comment upon it?
Yes, of course. We have, actually, I agree. It's a very good question. We receive these questions a lot lately because in our guided autonomic testing application, Valsalva is one of the maneuvers. What we do, we deliver a disposable mouthpiece. So, just one single use, and then you connect a new mouthpiece, and so there, in that way, we reduce the risk of COVID-19 infection. Yeah, and of course, I completely agree. When you feel sick, stay at home.
That makes a lot of sense. Arthur, do you use Finite systems alone, or do you measure brachial blood pressure in addition?
Actually, in the lab, in the Cardiovascular Autonomic lab, we don't use anything else because the Finite unit has a built-in brachial measurement system, which is used for calibration of device just before you start your measurement. So we feel pretty confident with this system. We don't need another system at our lab. We have the brachial device as well, just in case. We don't use it actually at all. But brachial measurement systems are instead recommended for not continuous but interval measurements of ambulatory character, 24-hour ambulatory blood pressure monitoring. Then you use the brachial system instead. But for the cardiovascular autonomic lab, the Finite system is completely sufficient.
That's good to know. Eric, did you want to touch on anything here?
Yeah, I think Arthur already answered the question very sufficient. But what is important to understand about the Finite Nova? We offer at the Finite Nova a brachial calibration. So then you see on the screen, on the monitor, you see actually the beat-to-beat brachial blood pressure real time. So so there is a brachial calibration option in the NOVA.
Great. Arthur, does the active stand test provide different information than the head-up tilt test?
Oh, yes, of course. Of course, the active standing test is the physiological process. This is a physiological one. And you are usually using your muscle pump to keep you standing upright and to compensate for the blood pressure, for the volume shift downwards in your body when you're standing. So this is more physiological, but it cannot be standardized. Some people cannot stand for such a long time as if they were standing on a head-up tilt table. Then, on the other hand, if you want to catch the initial so-called rapid orthostatic hypotension, as we demonstrated one of in our slides, then you have to use active standing. The changes are so fast that you need beat-to-beat blood pressure monitor and active standing to catch it when it happens. And the duration of the process is about 15, 20, 30 seconds. So if you don't use active standing and beat-to-beat blood pressure monitor, you cannot catch the initial orthostatic hypotension. And again, head-up tilt testing is ideal for long-term orthostatic challenge. Some people cannot stand for 20, 30 minutes, but you can easily do it while lying or standing on head-up tilt test. Then on the head-up tilt test, you can make people faint. You cannot make them faint while standing because they usually fall down or they try to protect themselves where they feel about to faint.
Okay.
So
sorry, go ahead.
No, I hope that I answered the question.
Sure. On this note, actually, the next question was, how dangerous is tilt testing? And is there a patient group in which head-up tilt test should not be used?
This is not very dangerous. We have had a few cases of tilt test invoked atrial fibrillation. This patient had it before, so it was just another procedure triggering atrial fibrillation, which was known. We have never had any serious accident in our lab. However, if you are pregnant, then probably we should not advise it in the first case. Then, if you are too young, in the age younger than 10, 8 years, we would not advise to do it. This is not very diagnostic. Then, to some degree, we want the patient to collaborate. The patient that cannot collaborate because of dementia and other disease affecting the central nervous system, I would not advise it here either. But we may perform the test despite these circumstances, because the information you can get through the test is so valuable that the exclusion criteria are very few, actually. This is not at all dangerous. This is good even if you faint, even if you demonstrate the cardiac arrest. I just showed you a diagram of a man who presented with cardiac arrest of 63 seconds. Of course, we may have implanted a loop recorder and wait until he would faint for the next time. Maybe he would suffer skull trauma or be even more traumatized. In this case, we performed the test at our lab. He fainted. It was very dramatic, and the staff was shocked, and the patient was shocked. I was not shocked. I've seen it before. So we decided on pacemaker, and everybody was happy.
Okay, good. And again, actually kind of carrying on, is there a place for a pacemaker in treatment with recurrent hypotension and bradycardia after initial investigation?
Oh, this is a really good question and a source of a great debate among syncope experts. Actually, the recent findings from different studies such as Spain, BioSync, and Issue 3 demonstrated that even if you develop hypotension during vasovagal reflex, if the bradycardia is the real cause of loss of consciousness, Then by pacing, you may avoid loss of consciousness. You may feel dizzy, you may not feel well, you may feel affected for a while, but in the end, you will not faint, you will not lose control of your body, you will not damage yourself. So yes, there is a place for pacemaker, and in our experience, according to different studies, 15 to 20% of patients who are paced against bradycardia during vasovagal syncope, even if they are paced, 15-20% of patients may still experience another fainting episode. And this is due to profound hypotension that we cannot deal with yet.
Okay. It's interesting. Eric, how can I be informed about new applications and software modules from FinePrep?
Oh, yeah. That's a good question. You can, of course, look at our website, where we inform everybody about the applications and the software modules. We also communicate very often via our LinkedIn and Twitter accounts. Normally, when we are able to travel, then we go to international conferences. And of course, you can also contact us directly, or contact our distributors by email or telephone. We are happy to help you with all your questions.
Perfect. Thank you. Artur, back to you. When do you take action if you provoke asystole?
I knew someone would ask this question. This is very tricky. Actually, this is just a reflex, and reflex, it starts at one point and it comes back to the baseline after a while. This is exactly the same with reflex syncope with asystole. It starts at one point, and there is this period of asystole, and you may see the jerking movements. It looks very dramatic, and it looks like the person in question is just about to die, and then he just breathes in a few times and then wakes up. So it is because the asystole may have different duration. And I showed you an example of a very prolonged duration of asystole of 63 seconds. We had another case a few weeks ago, 83 seconds actually. This is very long. And of course, such a long asystole may produce profound hyperperfusion in the brain. Usually we decide on cardiac massage when the asystole exceeds 30 or 45 seconds. Then we try to start cardiac resuscitation, heart and lung resuscitation, of course. So, but in some cases, you want to wait a little bit and see, and usually you see the QRS complexes on your screen after a while, and then you feel safe.
Okay.
So I know it sounds dramatic, but this is the real life, and they always come back. All people with reflex syncope, they always come back. It may be very dramatic, and usually we will not allow them to stay unconscious and without circulation for more than 1 minute.
Okay, that's good. Okay. In the interest of time, I'm going to make this question our last one. What would you consider the essential equipment needed to build an autonomic laboratory? And are there other non-tilt tests that might be important to conduct it as well?
So, in the first place, good training, good knowledge, and your brain open-mindedness. So you have to combine all these elements into one good workup, and we try to make it into a sort of algorithm, a sort of basic autonomic testing in the current guidelines that I would recommend. Then, in our place, we use motorized tilt table which we can lift and then make it fall down quicker if it's needed. Then we use a good beat-to-beat non-invasive hemodynamic monitor. There are only a few manufacturers in the market now, and you should buy a good one, reliable one, with the possibility of offline analysis after the test. So you need good software to reanalyze the course of events, as what's happening during the test may go really, really fast. So you cannot analyze it on live. And then in our case, we added cerebral saturation monitor as an important part of diagnostic workup. But tilt tape and good non-invasive bit-to-bit monitor are the basic parts. And then, of course, different elements like Valsalva, like deep breathing. It depends on instructions given to the patient. So you should get good training as well.
Okay, wonderful. Well, thank you both so much for this wonderful Q&A session. And thank you so much for all of your insights today, Dr. Fedorowski, through your presentation and again through this Q&A session. And of course, a very big thank you to Finite Medical Systems for making this event possible.